So the IRIS pudding was a collaboration between the 6 trials, randomized controlled trials, that compared direct endovascular treatment without preceding intravenous alteplase to intravenous alteplase or tenecteplase in a small number of patients, followed by endovascular treatment. Because right now the thrombolysis prior to endovascular treatment is a standard of care, because the initial trials proving the value of endovascular treatment only studied it as an addition to the lytic rather than comparing it to the lytic. So these 6 trials were performed to study if we can maybe drop the lytic from the treatment paradigm. And they found kind of conflicting results, right? So 2 of them done in China found non-inferiority of the treatment without thrombolysis, and the other 4 were inconclusive. So with these trial teams from the 6 trials from China, Japan, Australia, Switzerland, and the Netherlands, we collaborated to merge all of those data and perform the pooled analysis. In total, there were over 2,000 patients pooled. And we, or actually Johannes performed an international survey study asking physicians from all over the world what they would see as a usable non-inferiority boundary. And that was 5% difference in functional independence rate. So most of the physicians said that if the lytic was withheld, they would accept a maximum difference in the rate of functional independence of 5%. So this was our non-inferiority boundary, which means that the 95% confidence interval around the effect estimates for outcome can't go below this 5%. And the 5% translated to an lower confidence interval of the adjusted common odds ratio of 0.82. This is important because this boundary is quite relevant, because it determines when you call your finding significantly non-inferior or when you call it inconclusive. So we took this boundary, we pulled the data of all the patients, and we found that the differences in outcomes were very small. The results were actually very similar, but the lower boundary of the confidence interval was actually at 0.76 rather than 0.82. It was also above, the upper limit was also above 1, and the point estimate was slightly towards benefit of the treatment paradigm with lytic. But so it was a non-statistically significant difference just below the non-inferiority boundary. So that means that despite 2,000 patients being included, the results are still inconclusive. What we did see is that so there was also no benefit of adding the lytic. B, there was a higher rate of successful reperfusion during endovascular treatment with intravenous thrombolysis, but there was also a higher rate of any intracranial hemorrhage, not a higher rate of symptomatic intracranial hemorrhage. So it seems like there's a bit of a trade-off, like the results are really similar. There's still some heterogeneity going on, making the confidence interval so wide that we can't say it's non-inferior. And there's a bit of a trade-off between more successful reperfusion with lytic, but also more hemorrhages. This is what we found in the main analysis. And so our main conclusion was that despite the inconclusive results, there also was no benefit of adding the lytic, and the treatment effect was around 2%, 2% higher chance of achieving functional independence at 90 days with the lytic, which would mean that 57 patients would be treated. So the number needed to treat would be 57 with the lytic to get one additional patient with functional independence. This is quite small compared to the effect of endovascular treatments, because there, like I think most of the people in the field will know, the number needed to treat is something like 3.4 or so. So that is really the treatment that is going to help patients. That is what we should be focusing on.
Having those results, you have 2 options. I think you can go down a more formal conservative approach, and you can go into a more, let's say, philosophical approach, I would say. So the more conservative approach would be what has been also done by the ESO-ESMIN guidelines, say that you haven't reached non-inferiority, and that was your goal. And by that means unequivocally that intravenous thrombolysis plus endovascular treatment or thrombectomy will remain the standard of care. And that is the recommendation. And when that came out, some people criticized that the non-inferiority boundary was set too low. It was at 1.5%, which is the minimal clinically important differences for stroke trials. But now we have the same results, so an inconclusive result, not showing non-inferiority for 5%. So these people will argue that these data unequivocally lead to the fact that intravenous thrombolysis plus thrombectomy should remain the standard of care. Then on the other hand, and as Manon pointed out, that we know it's clearly not superior. We know that the point estimate points toward a very small effect. And you can always go back and say, okay, why were the initial thrombectomy trials, like the initial successful thrombectomy trials, were comparing thrombectomy plus IVT versus IVT, or if the patients were eligible. And that, I think, was due to the case that the initial not successful trials in thrombectomy tested IVT versus endovascular treatment in general, at least 2 of the 3 unsuccessful ones. And if their thrombectomy or endovascular treatment would have been successful, nobody actually would have questioned if you can give IVT in this scenario before endovascular treatment. So I think, depending on the sequence and the history of the trials, you would have gone down a different road. You have either tested superiority of intravenous thrombolysis before thrombectomy, or as it is now, you have tested non-inferiority. And would you have tested superiority, like Manon said, there is no statistical significant benefit, and then the interpretation would be that thrombectomy alone or endovascular treatment alone would be the standard of care. So having this in mind, I think there are two approaches to these results. But we have to also stick to our formal approach, and we used a non-inferiority boundary, which was not chosen freely, but that has been backed up by some data indicating that this is the most chosen answer of an acceptable uncertainty physicians around the world are willing to accept. So we also have to go with that.
Yeah, and then the question is also, I think, a bit broader than just this topic of intravenous thrombolysis prior to endovascular treatment for stroke, right? Because we're in a situation where an additional treatment seems to have a small effect, but it's not proven to have a statistically significantly positive effect. If you choose to stay with that treatment for all of medicine, you can add an unlimited number of treatments, which will lead to increasing healthcare costs, right? So at which point are you going to say we're going to leave the treatment out if it doesn't have an additional effect, or if we're not sure whether it has an additional effect? I think it's a question that is bothering many fields in medicine right now.
And also, I think in the light of drug shortage for alteplase affecting at least some countries, it is important to prioritize patients in a way. And if we now know from IRIS data that the point estimate is first non-significant and the point estimate is plus 2%, and we compare that to the overall IVT versus placebo population, it turns out that if you're going with the numbers there, that the population of patients with large vessel anterior occlusion stroke is certainly benefiting less from IVT than the overall IVT versus placebo population. So if you want to prioritize in such a scenario, it has become clear, having this data, that probably these patients are the ones to skip IVT.
That is kind of what you were heading towards, Johannes, as well. that it is not a one-size-fits-all kind of approach anymore right now, because the confidence interval around the effect estimates are quite wider, indicating that there should be some kind of heterogeneity disturbing the security of the point estimates. So you would say that based on, for example, the occlusion location, the like really large vessel, proximal occlusions would benefit less. You could kind of prioritize the patients you would give the lytic to, especially in the setting of shortages, but maybe also just in general, so that you're not giving a treatment which carries some risk to patients who will not benefit from it. So we did quite a few subgroup analyses in the IRIS pooling. From the top of my head, it was like for age, sex, aspect, NHSS at baseline, time from onset to groin puncture, and onset to presentation, I think, to randomization, as well as occlusion location and tandem lesions. And all of those did not show statistically significant interaction, meaning that the effect of adding the lytic before endovascular treatment was not significantly different between the groups, except for onset to onset to groin puncture time or randomization time. So for patients that were presenting earlier in their window, that had a shorter onset to randomization time, they seem to benefit more from adding the lytic as compared to patients who presented a lot later. That was the only thing we found, with one little catch, that in all these subgroup analyses, we did quite a few. So technically speaking, there is a chance that it's a finding based on chance, right? For every 20 tests that you do, one is going to be statistically significant just based on luck. So actually the Swiss group, together with the rest of the IRIS people, is going to do a sub-study on these times to dive into that a bit deeper. What are your plans for the time subgroup analysis, Johannes? What is your gut feeling also about that?
My gut feeling about the timing? I mean, yeah, I think the problem there is, I think, twofold. So first, if you show heterogeneity, that does not necessarily mean that you can individualize the treatment of the patient, right? So this is, I think, a methodological concern in general for individualized treatment decisions that is sometimes hard to grasp. And I think there we can learn from cancer studies, for example, because that is an explorative study you're doing there. And what you're basically suggesting is that an individualized approach, for example, considering timing, for giving IVT or not giving IVT, is better than the standard approach, right? And to show this, you would have to show this in a randomized trial then, right? That the individualized approach would be better than the guideline approach, let's say. I think showing this, you really need thousands of patients. So there was a lot of hope, actually, I think, for IRIS data in particular, that we found large heterogeneity effects, and then is everything clear and you can run another trial in the subgroup. But in the end, it turns out it's not that clear. And I think the hope for finding in the very near future, like a good working individualized treatment approach, are not that high. But that is my general opinion. Yeah. I think that people believe differently. So.
Yeah, I think like it's a statistically speaking, it's a really difficult problem, of course, because statistically and practically, you need quite some patients to find statistically significant interaction for a treatment, or the effect has to be really strong. But also, like, who has the money to do randomized controlled trials for every subgroup you're going to find, right? But there was a study by, I believe, Ghent. Thomas Manon suggested it to us for the prediction model study in the IRIS data, PFO, exactly, PFO closure. And there he identified a specific subgroup that does benefit from PFO closure. I think that was really elegant. Yeah, we could probably try something like that in the IRIS data as well.